Ladies and gentlemen, good evening. It's a great pleasure tonight to welcome Professor Clare Gilbert, who's going to talk to us about blindness in children, in particular the global perspective. Now, myself, I work with adults and I don't do any paediatrics at all. But when I work in developing economies and in towns which have problems with developing populations, such as Madras, Bombay, Jamaica, and in Africa and Liverpool, it's very striking that even as an adult ophthalmologist, you still have to deal a lot with children. And there are epidemics and different causes of children going blind. It's a really important subject because there is a lifetime burden of blindness, which is not only tragic for the people concerned, it's absolutely desperately tragic for the economies that have to deal with these people who are no longer going to be productive but are going to be dependent. Clare is a wonderful speaker and is an expert in this field. I met her when she had just discovered a whole school of people who are blind from retinopathy of prematurity in Chile. And I'm going to now turn over to Frank Cox, who will introduce our speaker for tonight.
Thank you very much, Will. It's a great pleasure to introduce the speaker tonight, especially as she comes from the London School of Hygiene and Tropical Medicine, where she's Professor in International Eye Health. The other details from the board there already would save me a lot of trouble. She's co-director of the International Centre for Eye Health, and she's a clinical consultant with Sightsavers. Her world interests are, in fact, in blindness in children, and particularly her work has taken her to Bangladesh and also to South America. But today she's going to give us a much broader outlook on blindness in children, and the title is Blindness in Children, A Global Perspective. Clare.
Good evening, everyone. It gives me enormous pleasure to be here, and I'd like to thank the organisers very much for the invitation. As has been said, one of my research interests is blindness in children, but at the International Centre for Eye Health we also do other research, which I won't tell you about because time does not permit. This is an overview of what I will tell you about. First of all, I'll tell you a little bit about the organisation where I work, so you have a feeling for the context and the contacts that we have. I'll then tell you a little bit about some of the challenges of doing research in developing countries and highlight some of the extra challenges of doing research into blindness in children. And then I'll tell you what we know about blindness in children, how many children are affected and what the causes are. And then I shall finish off by telling you about two bits of research that I've been involved with, working with colleagues in and from Brazil and Bangladesh, and two diseases in particular. One is retinopathy of prematurity, and the other is cataract in children in Bangladesh. So you may be a little bit surprised, because I expect you've all heard that cataract can affect adults and is a very important cause of visual impairment and blindness in developing countries, but it also affects children. So, the International Centre for Eye Health, we're 30 years old this year, and we're based at the London School of Hygiene and Tropical Medicine, where we moved just 8 years ago. And I must say we're very happy in our new home because we're surrounded by people who are like-minded and have a public health approach to the control of diseases. So our mission is research and education to improve eye health and eliminate avoidable visual impairment and blindness, with a focus on low-income populations. We've been a WHO collaborating centre since we were established, and the International Centre for Eye Health is our WHO collaborating centre name. And to fulfil our mission, we have these three main areas of activity. Firstly, research, secondly, education, and then making sure that we disseminate the findings from our research to people who need to know it. So the different types of research that we are involved with are broadly the different types of research that you need to get the evidence to address diseases and their control in populations. So we do epidemiological research, and I'll tell you what the definition of that is in a moment. Operational research, which is when you know what to do but you're not quite sure of what's the most effective and the cost-effective way of delivering an intervention. Health systems research is seeing how a health system can work to be more equitable and more effective. Health economics is to do with the costing and what's the most cost-effective way of delivering an intervention. And qualitative research is a bit different. This is finding out about perceptions and understanding and knowledge so that you can tailor health education programs for people starting at the point of what they already know and do. So we try and do all these different elements of research so that we have a broad overview and a broad range of evidence and tools at our command we can bring to the control of eye diseases. This is a map of where in the world we are currently doing research or where we have done research, and much is in Latin America, which is where I have done quite a few studies with colleagues. In terms of education, we run a master's in community eye health, and we also have a diploma, and this map shows you where our students have come from, and most of them come from developing countries, mainly in Africa and in Asia. Also under our heading of education, we produce a journal of community eye health, and this goes out free of charge 4 times a year, and we now have over 35,000 people on our readership database. And these are the different languages that we now distribute. We produce the English version in London, working often with past students, and we have a circulation of 20,000, and then this edition is translated into these different languages that you see here for distribution to Francophone African countries and to the Lusophone African countries, which are the ones that are really the most deprived of educational materials. And this shows you the map of the distribution of where our readers are located. Most of them are eye doctors or eye nurses, some are managers, and others are other healthcare professionals. As a group, we have very close collaboration not only with other groups within the London School, but also external to the school. And as Frank has already mentioned, I'm a clinical consultant to Sightsavers, which is the UK organisation that supports prevention of blindness activities, mainly in Asia and in Africa. But 3 other members of staff are also closely affiliated with other international NGOs, and this keeps us rooted in reality because we go and visit their programs, we give advice, we visit the hospitals that they work in, we meet patients, and we see the communities that they are working in. And so this contact and close working with these organisations helps us to respond to the needs for evidence and the needs for education, so that we can very much respond to the needs on the ground. As I've already mentioned, we are a WHO collaborating centre, so we work closely with WHO and try and fulfil the evidence gaps that they have identified. And we also work with the International Agency for the Prevention of Blindness, which is an umbrella organisation of all the NGOs and all the professional bodies involved in blindness prevention and the corporates who support eye care. So all these different organisations all contribute to our education and research agenda and also provide a mechanism for dissemination of our results. So we have synergies between the different areas that we work in, as well as having quite a broad scope of different stakeholders and partners. So just to come back to epidemiology, epidemiological research answers the following questions. It asks how many people in a population that we're interested in have the disease that we're interested in. And there are 2 different measures. One is prevalence, which is a measure of the proportion of people in the population who are affected at a given point in time. And the other measure is incidence, which is the rate in the population at which people develop the disease that you're interested in. So these are 2 quite different measures, and they're both useful for different purposes. Another question epidemiological research addresses is who is most affected by age group, by gender, by occupation, by where in the population they may live. And there's 2 reasons for asking this question. Firstly, because we need to know who to target for services. And secondly, it can be quite useful for generating hypotheses about what might be causing a condition if only a certain subset of the population are affected. Another range of study designs address the question, why do people have the condition? And then there's another huge body of research that is done to investigate what can be done to prevent or to treat the condition. And here the gold standard is randomized, double-blind clinical trials. So just to tell you, move on now to talk a little bit about epidemiology of blindness in children. And this is Dr. Fatima Kiari, who is currently doing a PhD with me in Nigeria. And she is examining one of the children who was a participant in the National Survey of Blindness and Visual Impairment that we recently completed in Nigeria. She's a past graduate. So this shows you how our past students can also take part in research. First of all, I want to talk about some of the challenges of doing epidemiological research, or any kind of research for that matter, in developing countries. Much of the data that we have about disease frequency and who is affected and what treatments they are receiving comes through routinely collected data through our information systems within the National Health Service. But unfortunately, outside the industrialized world, health systems are weak, and systems for collecting routine data are also not in place. And this means that there is a whole potential source of data for research that is not available to us. This means that we have to go to the population to find the data that we need, which makes data collection more complex and more expensive. In the UK, we only have one service provider, the National Health Service, but in many other countries, particularly in Latin America, there's a plethora of different service providers who all have different ways of doing things. And here again, this adds to the complexity of trying to collect data in a standardized manner. In much of Africa and the developing world, subspeciality ophthalmology is not in place, and people are trained as general ophthalmologists. So if we're wanting to do research into blindness in children, for example, there are very few, or there have been very few ophthalmologists who have the relevant skills and expertise to be able to examine children and give a confident diagnosis. Given the huge need for delivery of services, there's often not a research culture, and there's a lack of research institutions and people who have been trained. But this is something that the World Health Organization is really trying to address at the moment. And we are hoping that our MSc students can also contribute to this building of capacity for research. And then one also has to consider that we who are interested in eyes and blindness are in competition with other funding agencies and other researchers who may be more interested in diseases which cause people to die, such as HIV and AIDS and TB. So the challenges are considerable. And when we come to talk about blindness in children, there are some other things that make life a bit difficult. And this is because children don't complain. In fact, a child can be almost completely blind and they won't complain that they can't see. And this is because they don't know any different, and they don't know that other children can see differently from them. And this means that you have to be more proactive and also take notice of what parents might say and what they have observed about a child's behavior. Children don't like to be examined, although I must say, in my experience, examining children in developing countries is a far sight easier than examining children in the UK. Communication is difficult, so if you're trying to, ask them to measure their vision, trying to get them to understand what you're asking them to do is also difficult. And this means that standard methods can't be used. And in terms of blindness, it's rare, or it's relatively rare, and this means that we have to have large studies. So this may all sound like an excuse, but it's a backdrop to, and an important backdrop to, so you understand the difficulties in obtaining some of this information. So what this means is we have to be creative, and we have to take opportunities as they arise, which may mean that we put blindness in children or blindness into studies that are being done for other purposes. And what I'm going to tell you about in a moment is the key informant method, which is a novel method which was refined and developed by one of my PhD students in Bangladesh. And this is proving a very useful approach to the study of unusual diseases in populations. In terms of information on the causes of blindness in children, much of the early work was done by examining children who are enrolled in schools for the blind. And in the photograph, you see a photograph of me some years ago, it has to be said, measuring the vision in children in a school in Uganda. You can also examine children who are identified through community-based rehabilitation programs. And again, the key informant method can be very useful in providing information on the causes of blindness in children. So, whenever we do epidemiology, we have to start off with definitions so that you know exactly what it is you're trying to measure in the population. And these are the definitions that are used for the epidemiology of blindness in children. So, we are using the definition of childhood of 0 to 15 years, and blindness is defined as less than 3/60 in the better eye. And I will explain what I mean by that. Now, you're all going to be familiar with these visual acuity or vision testing charts. The one that we normally see in the UK is the one with the letters here. But for measuring acuity in populations who are not literate, we have to use other symbols or letters. So for the C's, you ask the person to identify where the opening is in the C. Or for the E's, you ask them to point in the direction that the E's are pointing as the different letters are indicated. So it's usual to test the vision at 6 meters, but blindness is defined as 3/60, and what this means is that the person cannot see the big letter when they're tested at 3 meters. So this is quite in their better eye. So this is quite a profound level of visual loss. When we're thinking about measuring vision in children, we can only use the letter chart on children who go to school over the age of 10. It's only about that age that they are going to know the letters. For the C and the E's, children can only kind of get their hands to coordinate properly if they are 5 years and above. So this means that we're a bit stuck for measuring vision in children who are yet less than 5 years of age. And so we have to use other testing methods, some with symbols and matching tests and these paddles with stripes on. I haven't got time to explain exactly how they work, but there are different methods that we need to use for children. And we also sometimes have to use toys, and which means having a very messy clinic and not being frightened to make a complete idiot of yourself as well. So this ophthalmologist here is seeing how this child is responding to the face of the child as he moves it above his face. If the child can see, then she will fix and follow the face of the toy. So what do we know about the epidemiology of blindness in children? This graph here shows you all the available data that has been published since 1990. So this is 20 years of different studies where we've been able to extract information on the prevalence of blindness in children. And just recall that the prevalence is the proportion of people in the population who are affected. And because blindness in children is quite rare, we measure the prevalence per 1,000 children rather than as a percentage. Each of these spots represents data from a different study, and the data have been plotted against under 5 mortality rates, which are also per 1,000 children. And with the eye of faith, what one could see is that in countries that have got very low under 5 mortality rates, so that's the spots on the left, the prevalence of blindness is also low. Countries that have got higher under 5 mortality rates, the prevalence of blindness is higher. And we are now using under 5 mortality rates as a proxy for blindness in children. So for all the countries that do not have data, we can use their under 5 mortality rate to estimate what the prevalence of blindness in children might be. And you may think, well, why do that? And this is because blindness in children and child mortality have got very similar determinants. They're both related to poverty, and they're both related to having uneducated mothers. They're both related to poor nutrition, poor infrastructure, poor health services, and poor access to specific interventions that not only prevent mortality, but which also prevent blindness. And the two important diseases of childhood, which not only cause children to die, but which also cause them to become blind, are measles and vitamin A deficiency. And now, over the last 15 years, there have been enormous programs to control these two conditions through WHO with support from the major UN agencies, and in most countries of the world now have reached their target of at least 80% of children under the age of 5 immunized against measles. And fortunately, the vitamin A can be given at the same time as the measles immunization, which means that they can get two major life-saving interventions at the same time. And this is also having the impact of reducing corneal scarring in children from vitamin A deficiency or measles, which is why the little girl in the picture is blind. She's got this white scarring of the cornea, which is the cornea is the front of the eye. And since the early 1990s, under 5 mortality rates have also been used as a proxy indicator to determine whether vitamin A deficiency is a public health problem. So we feel that there are other groups who are now also realizing the value and importance of using under 5 mortality rates. This is a graph in 1999 to show the estimated prevalence of blindness in children in different countries in the world. And the green countries are those with a very low prevalence, around 0.3 to 0.4 per thousand. And as one might anticipate, Africa is the region with the highest under 5 mortality rates, and so the highest estimated blindness prevalence in children. But as we probably all know, under 5 mortality rates have been dropping more rapidly in some regions of the world than in others. And if you look at the distribution in 1960 on the left, you see that they are quite widely distributed. But if you now look in 2005 on the right, Sub-Saharan Africa is trailing behind, and the rate of fall in under 5 mortality rates in Sub-Saharan Africa is not the same as in other regions. And this is reflected in this map here, which, if we're using under 5 mortality rates to indicate the likely prevalence of blindness, what we see is much of the world that was orange and yellow has now become green, but countries in Africa are still likely to have a high under 5 mortality rate. I shall come back to this in a moment when I talk to you about Bangladesh. So we've used these data from these proxy estimates from 1999 and 2010 to estimate the number of children in the world who are blind. And in 1999, we estimated that it was 1.4 million, and there's been a 10% reduction until the year 2020. All regions of the world, we reckon, have had a decline in the number of children who are blind, apart from Sub-Saharan Africa, which are the columns on the right. And this reflects not only stagnation of decline in under 5 mortality rates, but also it's the only region in the world where the number of children is continuing to grow. I just must point out that these regions are using the World Bank designation, with the countries on the left in the former socialist economies and the established market economies on the left being the most affluent, then Latin America and Caribbean, then the Middle East Crescent. OAI is Other Asia and Islands, so that's Philippines, Indonesia, Bangladesh, and Sub-Saharan Africa on the right. So moving on now to think about the causes of blindness in children, we worked with WHO to develop a new way of classifying the causes of blindness in children in 1993, and this was adopted by the World Health Organization, and now nearly all the studies that are published are using this system, which is great because it means that the data can be compared between the different studies. And we use two different ways of classifying the causes. One is a simple descriptive way which just describes where in the eye or the visual pathways the major problem lies. And the second uses the time of onset of the condition that led to blindness. And it's useful to have both, because when you examine a child, you can always say where in the visual pathway the pathology lies, but you cannot always say what the underlying cause was. So a little bit of anatomy for you. This is the parts of the eye showing the cornea, which is the transparent, clear front window of the eye here. This is the lens of the eye, which is normally transparent and completely clear. And when the lens becomes opaque that you develop a cataract. The retina is the thin neurological tissue that lines the back of the eye and which converts the light energy into the electrical impulse, which goes up the optic nerve to the visual cortex in the brain. So the first classification uses where in the eye the major problem lies. The second classification, the time of onset, uses a life course approach which has been developed by pediatricians, and they talk about these different time periods at which you may need to intervene to control diseases in children. And exactly the same applies for blindness in children, because during adolescence we may want to detect mothers and their husbands who have genetic disease. During pregnancy there are infections that can go across the placenta and damage the developing baby, and there are also genes that are responsible for controlling how the eye develops and grows. If there is obstructed labour, then this can cause brain damage, which can give rise to damage to the brain and visual loss in that way. Newborn babies, they can develop conjunctivitis of the newborn, which is when the baby contracts infection from the birth canal, and if the mother has got gonococcal infection, then the baby can acquire gonococcal infection in the eye, which can be absolutely devastating and blinding. And if the baby is born premature, then they can develop retinopathy of prematurity, and I'm going to tell you a little bit more about that in a moment. And then the child can be born completely healthy, but can develop a disease or a condition of childhood which can cause them to become blind. And in developing countries, certainly measles and vitamin A deficiency have been the most important, as have the use of traditional eye medicines, which is TEM, and I'll mention that a bit more again in a moment. So blindness in children is complex. There are lots of different causes, and there are a range of interventions and strategies that are needed for control, which can extend from the community for prevention right through to the need for very sophisticated surgical services at the tertiary level of delivery. So what do we know about the causes of blindness in children? We've now got data on over 32,000 children from 43 countries. I didn't examine them all. There are now many colleagues who have been using the WHO method to record the data. And what this has shown is marked variation in the major causes of blindness in children. This little crocodile of children I saw at a school in Thailand, where a lot of these little children were blind from retinopathy of prematurity. And I just want to point out one thing, is that children who are congenitally blind, they don't know that there's a world out there. So they walk around with their head down, because it doesn't actually make any difference if they have their head down or their head up. And this is one of the things that early rehabilitation of children emphasizes, is to try and make sure they have a normal posture and a normal affect, so that they aren't, so they can not appear quite so different to their sighted peers. In affluent countries, if we were to take a population of 10 million, around 20% of that population would be children, so that's about 2 million children in a population of 10 million. And if we use that under 5 mortality rate to estimate the prevalence, then around 0.3 in every 1,000 or 3 in every 10,000 children will be blind. So if we multiply the 0.3 per 1,000 by the 2 million, we come up with a figure of 600 blind children in a population of London, of 10 million, so in, say, London. And we know from the data that we have collected that most of the children in industrialized countries are blind from disorders of the retina, the lens, and the brain. And here this would come under others. In middle-income countries, the demographic distribution is a bit different, and around 30% of the population will be children. The under 5 mortality rates are going to be a bit higher, maybe 0.6 per 1,000. And so instead of 600 blind children in a population of 10 million, there'll be 1,800. And in middle-income countries, this is where retinopathy of prematurity is now becoming an important cause of avoidable blindness in children. In poor countries, there may be 3,600 blind children, and in these countries, measles immunization may not be complete, and vitamin A deficiency may still be a problem. And so around 20% of children are still blind from scarring of the cornea, as shown in the photograph on the right. And glaucoma, which can also affect children, and cataract is not adequately managed, either because children are not found or because they have the operations very late and their sight can't be saved. In the very poor countries, mainly in Africa, where the prevalence of blindness can be 1.2 per 1,000 or even higher, there may be 10 times as many blind children in a 10 million population as in industrialized countries. And here, corneal blindness, or the causes of corneal blindness, are not being controlled, and up to half of children can be blind from conditions which cause scarring of the cornea. The photograph on the right is unfortunately of a little girl who I saw when I was in Sierra Leone, and she had had very simple conjunctivitis, a viral form of conjunctivitis probably, which would have got better on its own without any treatment. But she used a local remedy, which was to use urine, and she had used urine from her uncle, which unfortunately was infected with, he'd got gonorrhea and was infected with gonococcus. So this little girl was blinded as a result of the use of that traditional remedy. You find people use traditional remedies as a last resort, and it usually means that there aren't eye care providers and services available, and people try and do what they can to treat or to prevent disease. So if we put all this information together, the number of blind children per 10 million population by cause and level of development, we come up with this schema. And what it shows is that in high-income countries, a relatively high proportion of children are blind from conditions that you can't do anything about. So in a population of 10 million, if you remember, there may be 600 who are blind, but most of them will be blind from conditions that you can't do very much about. Whereas in very low-income countries, we still have more preventable causes which we can do something about. And this schema is proving very useful for countries to come up with a rough estimate of not only what they think the number of children who are blind are in their population, but to also have a rough idea of what the major causes are likely to be. So if we're thinking about the avoidable causes, these are the ones that are highlighted in yellow, blue, and green. So the preventable ones are the corneal diseases, the treatable causes are cataract and glaucoma, and the retinopathy of prematurity is both preventable and treatable, as I will explain in a moment. So overall, over 40% of children in the world are needlessly blind, and most of the children who have avoidable blindness live in Africa and in Asia. As has already been mentioned, blindness can have a major impact, not only on the child, but also on their family and on their community. And I've alluded to the fact that children who are born blind have great difficulty in learning how to behave in a way that is normal, but it can also have profound effects on their development, not only their physical development, but also their social and emotional development. And this is because it's said that 75% of what we learn when we're small babies comes through vision. And I think all of us are very aware that when we meet babies, they really watch and follow what's going on, and they copy and they respond to their visual environment. So if a child is blind, then that opportunity for learning is cut off from them. So this is why, one of the reasons why it's very important to try and identify children who are blind early, to give them the treatment they need, not only to restore their sight, but also to try and overcome this developmental delay. Provision for schooling for children who are blind is woefully inadequate throughout the world, but particularly in developing countries where approximately only 10% of children who are blind receive any kind of education. So this will have a lifelong impact on their career opportunities as well. Having a disabled child in a family can cause enormous pressure and strain, and can lead to strained relationships and even family breakdown. And there's all the economic cost, not only because the child will not be able to go on and earn an income, but also the loss of the earnings of a parent who has to give up their time to care for a child. So the consequences of disability and blindness are enormous, and they extend well beyond the individual child. So what's being done about it? I'm pleased to say that in 1999, the World Health Organization and the International Agency for the Prevention of Blindness launched a global initiative for the elimination of avoidable blindness by the year 2020. And blindness in children is one of the 5 priorities for control. And this is a document that outlines the different strategies that countries can use. I just want to talk to you now about how research has strengthened programs and influenced policy within this Vision 2020 initiative, and I'll talk about retinopathy, prematurity in Brazil and Latin America, and cataract in Bangladesh. These are 2 very well-known people who were blind from retinopathy of prematurity, Stevie Wonder and David Blunkett. And this was a condition which was thought to have been a disaster of the past, because it was associated with giving premature babies too much oxygen. As soon as people realized that, they stopped giving oxygen to babies, and people thought this is the end of that as a blinding eye disease. Basically, retinopathy of prematurity only affects premature babies, and it's got very clearly defined stages which, if not treated in time, can give rise to a retinal detachment which is impossible to treat. So the key to retinopathy of prematurity is prevention and detecting it in time to treat it. Now, when I was examining children in Chile, what I found, to my great surprise, and also to the surprise of the ophthalmologists who were working with me, was that nearly 20% of children who we examined were blind from retinopathy of prematurity. No one had any idea that this was the case. And then this led on to other studies in other countries in Latin America and around the world. And we estimate that in Latin America there are 25,000 children who are blind from retinopathy of prematurity, and a further 30,000 who are blind in Eastern Europe and Asian cities. So, what are the risk factors for retinopathy of prematurity? Well, it's a bit like buying a house: location, location, location. It's prematurity, prematurity, prematurity. So the more preterm the baby, the more likely they are to suffer from this condition. But oxygen is still playing a role, and inadequately controlled oxygen is still a risk factor, as is infection and failure to gain weight, and inadequate services, including nurses who don't know what they can do to prevent the disease. So prevention can come through these different strategies here, but the 2 I want to highlight are excellent neonatal care and the role of eye doctors in examining babies and treating those who have got the advanced stages of the disease. And in Latin America, well, after this experience in Latin America, this made me ask the question of which babies should be examined for the disease. So I asked my colleagues to provide me data for the characteristics of the birth rate and gestational age of the babies that they treated. And this is data from Canada, US and UK, And this is what a full-term baby would be, 40 weeks. And what you see is these babies are all extremely premature. So only extremely premature babies are developing the severe form of the disease in industrialized countries. And our UK screening criteria are based upon that. So the ophthalmologists only examine babies who are less than 1,500 grams and equal to or less than 32 weeks gestational age. However, this is data provided by colleagues from all these different countries, and what we see is a much wider range of birth weights and gestational ages in the babies who are developing the severe form of the disease. And this is happening because we've got wildly varying levels of care for babies in middle-income countries. And this is exemplified in India. This is a very sophisticated unit in India where the babies have all the kind of care that you would expect in an industrialized country, but most of the babies who are cared for in the government sector are cared for in these kind of units where the care is woefully inadequate. So the implications of this study was that if we were to use the UK criteria to other countries, we would miss a lot of babies needing treatment and they would go blind. And also, all those bigger babies, they can be prevented, the ROP can be prevented with today's knowledge. So, this led me to do some research in Rio, absolutely beautiful city. And we did 2 projects in Rio. One was to address which criteria should be used for examination and can we prevent ROP. And I did some work with Andrea Zinn, who's an ophthalmologist, who examined babies in the 7 largest units in Rio de Janeiro. She examined 4,000 babies, and I don't know if you can see, but this is a pen here, and this is a footprint of a baby, showing you how tiny some of these babies are that are examined for this disease. And the findings, in a nutshell, showed that in the units which had got the better levels of care, where the babies were surviving, you saw only smaller babies developing the disease. But in the units where the care was not so good and the survival rates were lower, you had a wider range of birth weights and gestational age of babies developing severe disease, which means that you need to have different screening criteria involving the bigger babies in some units or the smaller babies in other units. If you were to apply just one criteria to all units to make it easy, so the ophthalmologists and neonatologists know what they're doing, this would increase the number of babies to be examined by 20%, but it would only need 12% more examinations. So the workload to find those extra babies is not as great as one might initially think. The points of care study was to address the question as does training nurses and providing equipment help to prevent ROP and other outcomes of neonatal care. And this is a 3-year study with a 1-year pre-intervention data collection. Then the nurses were trained and provided with equipment, and then after 1 year we had the follow-up data collection. The points of care is so that the nurses know how to control and reduce all these different factors which can increase the risk of bad outcomes, including retinopathy of prematurity in preterm babies. And just in November we went back to do a preliminary analysis of the data, and unfortunately, despite all this work, we found that there was no change in the rate of ROP in the babies or in other outcomes. And this may have been explained by a brain drain of neonatologists and nurses from the units that we were working in, because there was a severe shortage of personnel. What we were pleased to note was that the nurses were actually monitoring the babies better after the training than they were before, but this didn't translate into less retinopathy of prematurity. So in 1997, Eamon O'Donoghue and I ran the first workshop in Chile. At that time, no one really knew that ROP was a problem. There was very few ophthalmologists who were screening. Since then, there have been 30 workshops. Most countries now have programs. There's support for training and equipment from the NGOs, and there are government policies now in several countries which make examination of preterm babies an essential requirement. And it's only when programs get embedded within ministries of health and government do they increase their coverage and become sustainable. And control of blindness of retinopathy of prematurity is now the second goal of PAHO, which is the WHO for the Latin America region, which also will mean that there'll probably be more resources to controlling ROP in the region. Things are also happening outside Latin America with these two international congresses, which I was fortunate enough to be on the scientific committee for. National guidelines have been developed in China and also just last month in India. Eastern Europe poses a big challenge for reasons I don't have to go into. This just shows you what this all means in terms of the parents. This little boy was a very precious baby. His parents had been infertile for many years and had had lots of miscarriages, and he was identified and treated, and I think you can see by the way he's looking at the camera that he can certainly see after his treatment. Okay, switching continents, this is Bangladesh, a very, very different country indeed. It's the most densely populated country in the world. It's got 50 million children, and I'm just going to briefly tell you about some work done by Dr. Muhit, who was another of my PhD students. The questions we asked in this study were how many children are blind, why are they blind, and then what can be done about it. He developed and refined this key informant method, which I'll describe to you, and then he applied that to populations of 100,000 in all 64 districts across the country. So it was a national study. And the key informants are community volunteers who were identified and then trained in a one-day training in the different causes of blindness in children, what to ask for, what to look for. After that training, they were given 2 weeks to network in their communities. I must say there were 40 key informants trained for every 100,000 population. So they went back to their communities to identify children who they thought had visual problems. The families then brought their children to a site where a team of ophthalmologists measured the vision in the children, which you can see on the left, and examined them to confirm that they were blind and to identify the cause. The parents also received counselling from one of the field workers, and children who were blind were referred to the local hospital. And this is a family of 3 children who are blind from cataract. And what he found was among the nearly 2,000 children that he examined, he estimated the prevalence to be 0.75 per 1,000 children, which is almost exactly spot on what you'd expect if you used under 5 mortality rate as a proxy, which was very pleasing. And the main cause was unoperated cataract, affecting almost 1/3 of the children. Now, because of beliefs amongst the parents that congenital blindness cannot be treated, 85% of those children had never seen an eye doctor. They were just sitting at home and in their village. And as a result of this study, we were able to estimate that there are 40,000 children in Bangladesh who are blind. 12,000 of them were bilaterally blind from cataract, which can be treated to restore sight. But at that time, there was only one surgeon who was trained in pediatrics, and there were only 3 eye hospitals who could manage children. 2 of them were in the capital city, and they were only doing 300 cataract operations throughout the country a year, so nowhere near enough to meet the need in the community. So a collaborative project was established with Sightsavers as the main coordinating organisation, and the target was very ambitious, to find 40,000 blind children, where you can see the targets there, and to operate on 10,000, and to establish 8 to 10 child eye care centres. And 3 methods were used for finding children in the community, including the key informant method and those other 2 methods that you can see there. I was involved in the planning and the monitoring and also the midterm evaluation and the end of project evaluation in 2010. And going back there, it was absolutely wonderful to see that there are now 16 trained paediatric ophthalmologists. There are 8 tertiary centres well established. This project had identified nearly 33,000 blind children. Almost 10,000 were bilaterally blind from cataract. and over 24,000 cataract operations have been performed in children over that 6-year period, which was really staggering. I was really amazed by what they've been able to achieve. And this is some of the children who are in one of the eye units which had been upgraded and refurbished, and new equipment and training for children with cataract. And this is what I mean about a little girl being very compliant with being examined. This is a key informant with another family of children who she had found who were blind, and this is after they've had their surgery. And this is yet another family where the mother herself was blind, and she'd had 2 blind children, and the father had run away. He just couldn't cope with having a totally blind family. And these 2 children were found living in a slum in Chittagong, and they had had cataract surgery, and I think you can see by their cheeky faces that they can see me very well as I'm taking their photographs. And this is all children who've had cataract surgery back in action, doing what children do. The key informant method is now being used by our group to investigate other disabilities in children, and this is one of the examination camps that you can see for children who've got a whole range of other disabilities. So, what next? I think we need to do policy research for our retinopathy of prematurity in Latin America to see how we can advocate for and to get programs for ROP embedded within ministries of health. We need to evaluate the impact of integrating child eye health into government health systems, which is what will make them sustainable in the long run, and we need to scale up what we already know works. I'd like to acknowledge my colleagues and funding agencies, the team of fabulous people who I've been working with in Latin America, the team of people I've been working with in the UK and at the International Centre for Eye Health. Thank you.